All right, if our speakers could turn on the camera or join us. Awesome. All right, I think that's all of us. So I will, we can hang on another second just to give folks time to hop on the line. But for those who are just joining us, we are very excited to have you here at our 11th Biennial Asian American, Native Hawaiian, and Pacific Islander Health Conference. My name is Jennifer Wong, and I'm a program manager here at NYU Center for the Study of Asian American Health. And I'll also be your host and MC for this session and for the rest of the sessions today and tomorrow. We're very pleased to be co-hosting today's event with our speakers and with our colleagues and co-hosts at the Asian Pacific Islander American Health Forum, as well as our partners and sponsors at AARP. So just a housekeeping note for folks, friendly reminder that this session is being recorded. If you have questions for our panelists, please feel free to add them to the Q&A box. We will try our best to answer all of them, either throughout the presentations or at the end during our formal Q&A portion of the session. And I did also want to note to everyone that we're very happy to have a special guest with us during today's session or during this conversation, Sarah Yukimoto Saltman. She is a graphic artist who will be joining this session, the following session, and one tomorrow, and offering graphic recording, which will help sort of centralize and build connection across the different presentations to frame some key directions and action points to engage communities about the approaches discussed. And the final canvases that she'll be working on will be shared after the conference, which we will be sure to share with everyone. So if you have any questions, please feel free to either message me or add it to the chat, as I mentioned. But without further ado, I would like to introduce our session moderator. So Dr. Nadia Islam is an associate professor in the Department of Population Health, as well as an associate director of the Community Education unit in the Institute for Excellence in Health Equity at NYU Langone. And her work is very much grounded in collaborative approaches that include clinical and community stakeholders, and that focus on developing culturally relevant community clinical linkage models to promote and advance health equity. And I'm very honored to get to work with her, and just very happy that you're here along with our other speakers. So I'll turn it over to you, Nadia. Thank you.
Thank you so much, Jennifer, for that kind introduction, and good afternoon to friends and colleagues all across the U.S. I'm happy we're here together. I wish we could be together in person, but it's great to be here virtually with everyone. My name is Nadia Islam, and I'm really delighted to be moderating our first session at today's conference. I think for those of us who have been doing this work for many, many years, we can all acknowledge it's a really exciting time in health equity research for Asian American, Native Hawaiian, and Pacific Islander communities. We've had decades and decades of advocacy by community partners, community leaders, researchers, really decrying the lack of disaggregated and meaningful data for our communities. And I think we can all agree that this has resulted in real changes and action at the national and regional level, and namely the implementation of several national cohort studies representing the diversity of our communities. So while there's still a lot of work left to do, I take a lot of pride in how far we've come, really as a result of advocacy efforts to gain more impactful data in our communities. So today's panel will really showcase recent regional cohort studies on the engagement of Asian American, Native Hawaiian, and Pacific Islander populations. And our presenters today will discuss some of the innovative methods they use to integrate and sustain community engagement into these cohort studies, what study enrollment, recruitment, and retention looks like, and particularly reflect on the importance of these cohort studies in the context of the current research climate. So I'll begin by briefly introducing each of our esteemed speakers. We can spend an entire hour talking about the leadership of each of the speakers on our panel today. We are going to keep things brief, and I encourage our audience members to check out our conference website where the program booklet is, and more detailed bios are available. We'll hear from each speaker for about 10 to 12 minutes. And then I look forward to hosting a robust discussion and question and answer period following each of the presentations. So I'll introduce all three speakers at once and then turn it over to our first speaker. So first we'll be hearing from Dr. Joshua Grill, who is professor of psychiatry and human behavior, neurobiology, and behavior at UC Irvine, and director for the Institute for Memory Impairments and Neurological Disorders, or UCI Mind, as well as associate director of the UCI Alzheimer's Disease Research Center. Dr. Grill, its research focuses on clinical trials across the spectrum of Alzheimer's disease, including work on trial design, recruitment and retention, and research ethics. Next, we'll hear from Dr. Namrata Kandula, who is professor of medicine and preventive medicine at the Feinberg School of Medicine at Northwestern University. Dr. Kandula is a primary care physician and tenured, Dr. Kandula's work contributes to understanding how immigration, culture, and social contexts shape health and health disparities. She is one of the PIs of the Masala study that we'll hear about today. And last but certainly not least, we'll hear from Alex Chu, who is the director at NORC at the University of Chicago, a leading research organization where he is championing Amplify AAPI, the largest, most representative survey panel of Asian American and Native Hawaiian and Pacific Islanders committed to eliminating the needs, opinions, and experiences of AA and HPI communities. So without any further delay, I will turn it over to our first speaker, Dr. Grill. Please take it away.
Great. Thank you, Dr. Islam. I'm going to try to share screen, and if someone on the panel could verbally communicate that it's the right mode.
It is the right mode.
All right, very good. Thank you so much. So thank you, Dr. Islam. Thank you to all the organizers. It's a real honor and privilege for me to participate in this important conference. I am going to talk about CARE, the collaborative approach for Asian Americans, Native Hawaiians, and Pacific Islanders for research and education. I'll call it the CARE Registry because CARE represents a innovative and so far we think successful effort to try to improve representation of these groups in especially research focused on age, caregiving, and Alzheimer's disease and related dementias. So I'm Josh Grill. I'm from UCI, but really I have to say that I'm representing a large and highly collaborative group that's led by Dr. Van Ta Park at UCSF. Dr. Park is really the principal investigator for CARE and has done a marvelous job of spearheading this important effort that I'll get a wonderful chance to tell you about today. So CARE was originally funded by the National Institute on Aging through an R24 mechanism, which was really an innovative program from NIA to try to introduce the science of recruitment and efforts to improve representation in aging, ADRD, and caregiving research. We are really thrilled that it was recently funded through an R01 mechanism, with Dr. Park serving as contact PI for both of those applications. And I'm honored to serve as MPI of the R01 now. The registry itself was launched in 2020. If you want something easy to do, try launching a recruitment registry during a pandemic. But again, through the incredible leadership of Dr. Park and many, many community partners, this has been a successful venture so far, and we are nearing the launch of CARE 2.0 through this new funding that I'll tell you about. The goals are fairly straightforward. It's to give these communities voices in our research, to partner with them through community-based participatory research methods, and to increase representation of these groups in the research I mentioned. The registry is open to any adult from these communities, and it has been attempted in a very culturally appropriate, linguistic appropriate approach. 6 languages were included in the original CARE 1.0, and we are expanding those languages now. to greater facilitate the inclusion of diverse communities from the AANHPI sections of our nation. There's a strong community partnership in everything that we do, including a large community advisory board that guides us on the design and practices of the registry, including things like a small nominal gift that was given to every registrant who enrolled, and considering the data that we collect within the survey itself, the registry survey. We do collect data in the survey in order to understand who we're reaching, who we're not reaching, and to instruct our approach to connecting people to prospective research studies, which is really the name of the game for us. We're trying to increase representation of these communities in as wide a swath of research as possible, to make sure their voices are being heard and to ensure that the advances made through medical research will apply to everyone and benefit everyone. A wide variety of approaches have been taken to get the word out about CARE. There are extensive, many modal, many language types of interventions to facilitate recruitment into the registry. I've got a brief description or illustration of some of those here, but would really refer the audience to the CARE website to learn more about these things. The main driver of enrollment in the registry, however, has certainly been through community-based organizations and community partnerships. You can see a brief summary of the outreach that CARE has undertaken since our launch in 2020 here. You can see that there have been a very large number of community outreach events, primarily in the state of California. CARE was initially envisaged as a California-based registry, setting a goal of recruiting 10,000 AANHPI community members from the state of California in our first 3 years, funded through the R24 mechanism. And you can see that we engaged in largely statewide outreach. Although importantly, a lot of this outreach, because of the pandemic, was conducted through hybrid or online methods. And so our reach ended up being greater than we initially anticipated. We did successfully achieve our goal in the R24 funded 3-year period of enrolling 10,000 AANHPI members into this registry. You can see that the majority of them were based in California, but were born in another nation. They are, as is the case with many registries, predominantly females, something for us to work toward in the future, better representing men in this registry. About half of them indicated that they were proficient with English. And I think something that everyone is extremely proud of, 80% of the people enrolled in this registry had never participated in research before. And so we are achieving our goal of trying to increase the participation of communities who, to this point, have been left out of research in research programs. You can see the nationality breakdown of folks in the bottom right of this slide, with a broad inclusion, although predominance of a small number of groups, largely based off of the community-based partnerships that we had and the language capacity we began with in the registry. There is a lot of effort that's going into keeping these 10,000 folks enrolled in the registry through, again, multimodal types of interventions, again, partnering with our community advisory board and our community partner organizations to stay in touch, keep people engaged, and ultimately to facilitate them choosing to participate in research studies when invited. As I mentioned, we're thrilled to have been funded by the National Institute on Aging for an additional 5 years, in which we're going to dig deeper into the science of recruitment to learn from these people who are enrolled in the registry, and what they do when they are invited to participate in other studies. We will continue to embrace our community-based principles, and we have the goal of broadening to a wider swath of our nation, making this tool more diverse and more effective at increasing enrollment in studies. I should say we have referred more than 10,000 people to be in studies with a relatively high proportion of individuals choosing to then participate in the studies to which they have been referred. So this registry tool is achieving its goal so far, but we really are excited about the potential to expand to be a more national registry, inclusive of communities around the country, and importantly, facilitating increased inclusion in a larger set of studies, in particular, increasing the ability to support in-person studies around the country. One of my main goals in the registry is to try to communicate to investigators nationwide about the potential for this tool to be used to accelerate recruitment to in-person and online studies, as well as phone, and to improve the diversity of research samples. As mentioned, I'm part of an Alzheimer's disease research center funded by NIA, one of about 35 such centers. And we have a vision of seeing the ADRCs be more inclusive of AA and HPI communities in their own research and the ancillary studies that are supported through those ADRCs. We host quarterly brain trust meetings, webinars, where we try to make investigators aware of this powerful tool that could be used to support their own studies. I offer a illustrative flyer from one of those brain trust meetings, which will continue to occur throughout the course of our funding. When we successfully make investigators aware of the registry, there is a fairly straightforward approach for which they can utilize this tool. It begins by visiting the CARE website to learn more about the capacity of the tool and the ability to utilize it to support recruitment to your study. A brief form is completed by investigators wherever they are, and then a consultative review is provided by the CARE investigators. With relative efficiency, then, the goal is to supply those investigators with a list of registrants from the CARE registry who, in theory, will meet the eligibility requirements of their study, again, leaning on the data that we collect from participants when they enroll in the registry, to try to maximize the efficiency by not sending individuals who are, for example, not age appropriate for a given study to an investigator conducting that study. So we send lists of participants who theoretically meet the eligibility criteria for an investigator study, and then the investigator themselves is responsible for recruiting those individuals and carefully tracking the outcomes of whether those individuals were, for example, unable to be reached, but determined to not be eligible for something outside of what's collected in the registry, or enrolled in that study and participating in that study. This is important to our long-term goals, to demonstrating our effectiveness, and to tracking how we are doing in our ultimate goal of improving representation of these communities in research. I list the website for that referral form here in hopes that folks might take a screenshot or jot down this address and reach out to us if you're engaged in a study that would benefit from using the CARE registry as a tool to support your own research. I want to again acknowledge Dr. Park from UCSF, who is really the architect of this very powerful tool. Dr. Janice So is, along with me, MPI of CARE 2.0, funded by the new R01. But really, there is an army of investigators, advocates, community partners, and team members who have made the success of CARE so far possible. And I want to thank all of those folks, as well as the many, many people who have enrolled in the CARE registry so far. With that, I will conclude and stop share. Again, thank the organizers and look forward to our panel.
Thank you so much, Dr. Grill. Really inspiring to hear about these registry efforts as well as the plans for connecting them to other research to be able to expand the diversity of our trials and studies. So we're going to do a slight change in the order of speakers, and I'm going to turn it over to Alex Chu, who will share more about his work. Alex, go ahead. I think you're on mute, Alex, if you're speaking. Can you try again? Well, we can't hear you. I cannot hear you. I'm not sure if others can. You want to try again? No audio, yeah. Jennifer, any suggestions, troubleshooting?
Yeah, I'm wondering if Alex do you mind trying to call in, if that's possible?
Yeah, can you?
Yes.
Oh,
we can.
yes,
Okay,
perfect.
that's weird. Sorry about that. Let me share my screen. Hopefully that works.
I will let you know once it comes up.
All right, it should be coming out soon. And just let me know if it's similar to Dr. Grill, if you can see the right one.
Yes, it's on the correct format.
Great. All right. Only slight technical difficulties. But thank you for having me today. Well, similar to the conversations that built up, just wanted to give some background that led to the Amplify AAPI public opinion panel. There are 20+ million NHPI, and we're the fastest growing minority, and it's going to be the largest minority by 2060. But due to inadequate sample sizes, inaccurate data representation, we're constantly left off these major conversations, policies, budget allocations, and services. The lack of data and inaccurate data for the AA and HPI community has serious consequences, things like unequal access to social services, programs, consumer goods, harmful stereotyping and discrimination, and disparities in healthcare prevention, treatment, and care. And trying to get accurate and representative survey data for the community has been difficult in the past because there was no fully representative AA and HPI panel. And, like there were for other minority groups such as Hispanics, African Americans, or even other population segments like 50+, where there's many panels out there. And just for a quick background, a market research panel is a pre-recruited group of individuals who've essentially agreed to take part in studies such as online, telephone surveys, and IDA focus groups. But the largest barriers you can see on the slide for creating a panel for the AA and HPI community is, mostly market trends drive survey research to using online panels for efficiency. Existing panels are primarily in English or Spanish languages. As you can see on the bottom there, right, for this community, the majority of the immigrant population, 68%, is foreign born. Age 50+ is about 88% foreign born, and 49% have limited English proficiency. So it's key to be able to run these panels in multiple languages. Also, there's a lack of infrastructure makes accurate and quality AA and HPI representation 8 times more expensive in survey research. Because of all this, the questionnaire space and requiring translations to the community, really from data collection to reporting, it's just, it's much more expensive. So, and I'm going to the timeline background, but so we create Amplify API, which is the first ever and largest, most representative public opinion panel scientifically designed to accurately represent the AA and HPI communities. It's US households are randomly selected with a non-zero probability, and we conduct thousands of interviews in English, Mandarin, Cantonese, Korean, and Vietnamese. I'll mention this later because it's key. 92% of total AA and HPI households are offered this language, these languages which they are comfortable with. And compared to other opt-in online samples, which are only conduct surveys in English, you can see those types of surveys will leave out and won't be as representative as this panel that we have here. So building a first of its kind panel like Amplify API takes a lot of work. We spent all of 2022 kind of developing the infrastructure and the build out. In November 23, all researchers will now have the access to this high quality, cost efficient sample for survey research. And with increased funding that we received about a month and a half ago, we're able to run our second recruit, which by I would say fall, winter time of 2024, we'll be able to look at that key solution. I'll be able to look at disaggregated data for the 5 to 7 largest AAPI ethnicities. And then with additional funding in 2025, that'll be about going to the state level and just being able to, to just maintain this panel, which will make, bring those barriers that I mentioned before, make it easier for all researchers to access this community. So how are households recruited? It's a multi-step process that ensures that the most rigorous, high quality, most representative panel of probability sample, in which, again, the households are randomly selected using NORC's national frame, as well as ABS, our address-based sample frames. So NORC contacts sampled households in, again, randomized English, Mandarin, Cantonese, Korean, and Vietnamese that are likely to have these AA and HPI individuals. Is conducted through US mail, online, and telephone. The selected households visit our Amplify API member website or call our toll-free number. And then from there, after providing informed consent, the Amplify API panel members complete an introductory survey that goes into a lot of their variables and their background information, household composition, characteristics, interests. They are given $25 to join, and they get about $3 to $5 for each survey, which compared to other panels is much higher. And while obtaining a sufficient sample size is challenging, what really matters the most is having these methods in place to have a representative sample composition. And we achieve this by, like I mentioned before, multilingual communication. The 92% of the community is given the languages that they're comfortable with, and we're always trying to improve this. So hoping to add languages as we go on. The subgroup analysis, which focuses on getting more balanced sample to increase the sample, the size of the smaller AA and HPI subgroups, and then our cultural sensitivity. In addition to the languages, we have an advisory board of AA and HPI leaders from different backgrounds and ethnicities that advises us on topics and doing research to understand the nuances for the different ethnicities. And again, it might sound like a broken record, but I just want to repeat how critical it is to having multiple languages. You're leaving a large part of the community out if you're only doing English. So this is a little about our the origins of the 7 origin groups make up nearly 85% of all Americans. We can currently report on the total AA and HPI level, regional level, and Chinese. And again, as I mentioned, our goal of disaggregated data will really allow us to report on the 7 largest origin groups. And our born in the US versus foreign born is close to the census. We have a 34% born in the US, 66% born outside. You can see the age distribution is there. And then, right now when we look at the different regions, you can see that South Asian, East Asian, Southeast Asian, those are the countries are included in each of those regions. We're fortunate, this is a large endeavor. It's to get to that 2025 goal of maintaining the panel is about $6 million. We're about halfway there right now. And with our latest round of funding, we were fortunate enough to receive from RWJF, we're able to go after our second round of recruiting that will get us closer to that disaggregated data. And with that second round of recruiting, we're also trying to improve our collateral to our outreach, whether it's online, telephone, mail. And these are some details from the Census Bureau's 2020 communication efforts. I believe this was run by Y&J, but we refer to this to figure out how can we improve, enhance our responsiveness, get more of the community to join. So overall, and you can see I won't go into all these, but overall the idea is like shaping futures, empowering is a communication that you want to keep to. Basic education is necessary. Communications that depicted diversity and inclusive imagery worked. A lot of the panelists liked multiple ways of completing surveys with non-English speakers saying they liked potentially have that option to respond over the phone. But the little nuances in between is you take a look at the NH and PI community, imagery sometimes, right? Native language imagery were sometimes interpreted as appropriation. So, it's be able to target overall, but nuances within each of the ethnicity is critical. I mentioned my second recruit before. So what we're doing to enhance, and these are all the different collaterals that we use. And we have your newsletters, brochures, email invites. You have our postcard that we reach out, and then a reminder postcard, to remind them to participate in the panel. And the key here is that we're trying to make it more inclusive so we get increased engagement. So what we did for this second round, and it's actually working on this now, is we added more inclusive images. So you can see on that brochure on the left, which is in Vietnamese, we create this infographic that kind of shows the different ethnicities within the AANHPI community. One of the comments is on some of the brochures, the Asian Indian person was left out. So we've included, we already had that on some others, but now we included them on all our collateral. We revised our messaging based on that previous slide that I showed before. And we use language, we invite you and your family to join our AANHPI community and create a lasting legacy for the next generation to shape our future. So lasting legacy, next generation, shaping our future were keywords that really resonated with the different groups. And because we were shorter on the Vietnamese and NHPI community, we really wanted to use language to kind of resonate with them as well. We're also looking into contacting the community through random selection of prepaid cell phones, which are often used. These prepaid cell phones are often used by recent immigrants. So that was another way we could, reach them and have higher engagement. Another one we heard from our panelists, they wanted to be able to refer or nominate different people in their households. At NORC, AmeriSpeak, we want to first build trust, but then once we have that trust, then we can go back to them and then we can include those different nominations. So I know there's a lot on this, but just wanted to give a sense of all the large number of demographics that you're able to get as part of this panel. In addition to the usual demos like gender, age, education, household size, there's also nativity, languages spoken at home, Asian origin, online behavior, like social media use, as well as different personal finance profiles. And Amplify API is always evolving to be more inclusive. We heard from our panelists. We have open ends at the end of our surveys where we get feedback. And what they said that they wanted, the question that we had, language is spoken at home, originally was just, as you can see on the left chart over there, it was Mandarin, Cantonese, Korean, Tagalog, Vietnamese, and then other languages. They wanted to include more languages. So we were able to include all those languages before, and again, it's constantly growing. So we included Thai, Indonesian, Hmong, Punjabi, Japanese to make it more inclusive. I just want to show how different organizations are using Amplify AAPI. This is a sample of some of them, which started more as social justice and politics, has now really brought into healthcare, finance, caregiving, media habits, engagement. I'll share some actual data on the next slides, but here you see we have a relationship with AAPI data and AP-NORC. So there's a series of monthly polls, and I recommend everyone going there because it covers many different issues. We have a relationship with Rockefeller Foundation where they did a study on food nutrition security. AARP, as Jennifer mentioned before, is one of our founding funders. We work with them very closely. They did a survey on health, finances, loneliness, and then Kaiser Family Foundation did API healthcare survey. So I'm going to share some data. This is work we did with API data. We asked how serious a problem do you think racism is in the U.S. And as you can see here, AAPI adults versus all adults is similar, but 86% of AAP adults think racism is a serious problem, which is pretty much in line with all adults, but that was in April 2021 versus 2023. And in 2021 was really kind of at the height of the pandemic with all the racial unrest taking place. So, it's still a large problem with AAP adults and a concern. We asked AAPIs thinking about the problems facing the US and the world today, which we'd like the government to be working on. What are the top 5 problems? Inflation and immigration were the top issues. And you can see that AAPI adults overall are similar to US adults. 31% said inflation versus 30%. But then you can see the differences when you are able to look at the different ethnicities that US Black adults were only said 17% inflation. Issues like gun control were much higher for the African American community. And then on the right chart, you see immigration, which shows that more than twice as many AAPI Republicans than Democrats were immigration as a top priority, which is similar, but not as extreme as the US overall adults. Looking at the same question for, for younger versus older, we see that younger AAPIs under 30 believe healthcare reform, education, and housing costs are much more important than AAP adults over 60. This is work we did with the Rockefeller Foundation, looking at good and nutrition insecurity. 22% of the AA and HPI community reported facing food insecurity. And of those who did, 60% also face nutrition insecurity. And we looked into that question even deeper, like how does food and nutrition security vary among AA and HPI groups? And this is why that disaggregated data that we were always talking about and what you're trying to reach is so important, because overall it looks like similarities, but when you see here, even though the smaller sample size, the NHPI community has a larger number of, has more food insecurity and nutrition insecurity. The Vietnamese community also has a larger level of food insecurity. And then from work we did with AARP, asking a question, has the doctor ever told you that you had any of the following conditions? We really see that mental health conditions such as the anxiety and depression really stand out, but we also see that when we took a look at ethnicities like NHPI report much higher levels of most of these conditions compared to other ethnicities. This is also directional because of the lower NHPI sample size, but this is again why it's critical for that disaggregated data. I want to do a quick time check. Do I have a few more minutes? Dr. Islam?
Yeah.
Great. Okay. This is the work we did with the American Journalists Association, looking at sources that the communities, different ethnicities are improving. They feel they're improving our democracy. We see that for AAPIs, they're more favorable than other races, considerably more favorable with public TV or radio, print, digital news, and local television. On the chart to the right, when it comes to news sources that are making our democracy worse, APIs are on par with white, with being a little more critical than the Black and Hispanic communities towards sources like social media, cable TV news, and talk radio. We asked the question also about how do you stay informed about politics and current events. You see things like mainstream media outlets, 6 in 10 of the A and HPI communities are saying mainstream media outlets, over half social media, nearly half are saying local news. When you break that down, it's interesting. You see that the mainstream media outlets, it's higher indexing with the Gen X and the boomer and silent generation. For social media, millennials are 58% versus much lower, 41% boomer and silent. But when it comes to ethnic media, and we saw this with AAJA also, is that foreign-born rely much more on ethnic media. Here you can see the difference. U.S.-born stay informed, it's 5% versus 12% for foreign-born. So quickly about how you can access data. So we have around 1,000 to 3,000 respondents. The turnaround time is 5 weeks. We're constantly trying to increase the size of respondents to get to that disaggregated data and improve our turnaround time right now. I would say the most affordable way to do research is our custom survey option, is our monthly omnibus, which is 5 questions. It's $10,000. Each additional question is $1,500. Our ultimate goal that I mentioned before, we're halfway there for disaggregated data, but we're hoping by next year with additional funding, we'll start building panelists out at the state level. And then, in 2026, it'll be more about maintenance, so we can continue to keep this going. Our panelists take surveys once a month to keep them engaged, but we also don't overburden them. And the funding that goes into this will be able to keep the panel moving, and for us to be able to look at disaggregated data, but also data at that state level. And then, we want to thank all of our funders. A lot of funding, and we have a lot of partners that went into this type of endeavor. And you can see on the slide all the partnerships that we have that have made this possible. Thank you.
Thank you so much, Alex. I am going to move us right along so that we can have enough time for Q&A from the audience. I do encourage our audience members to start putting their questions into the Q&A feature. And in the meantime, I will turn it over to Dr. Kandula.
Hi, thank you so much, Nadia. I'm going to make sure you can see my screen.
Yes.
Okay,
Yep.
do you see the correct presentation view, not my notes?
We do.
Okay, great. Thank you. Thank you to CSAAH for asking me to present today. I'm going to be talking about the Masala study cohort and community engaged approaches for equitable representation in research. I have no relevant financial relationships. I receive funding from the NIH. So the goal of the presentation is to describe effective community engaged strategies for recruiting and retaining research participants from historically excluded and underrepresented groups in the Masala study cohort. So the Mediators of Atherosclerosis in South Asians Living in America study, or Masala, was established in 2010, initially funded by the National Heart, Lung, and Blood Institute. And our goals were to discover heart disease risk factors for South Asian Americans,
Nami, I think you froze. I don't know if others are not able to hear Nami as well.
Yes, I think I see her frozen as well.
Give it one moment. Oh,
Oh, did you lose me?
we did lose you just for a second, so, but we hear you now.
Are you,
Don't see the screen.
do you see my screen?
Yes.
You're not.
Yes, we were originally, the cohort was originally established in San Francisco in the Chicago area. And recently with funding from NIMHD, we've been able to expand to NYU, to the New York City area. And I'm going to give you a brief overview of our cohort's history and our different exams, and then get into our approaches for recruitment and engagement and retention. So the Masala study, as I mentioned, was established in 2010, where we had our first exam, where we recruited 906 participants who were largely of Indian origin from the Chicago and San Francisco areas. Those participants were brought back 3.5 years later for a second clinical exam between 2015 and 2018. And then at that time, we were able to expand our cohort by adding another 258 individuals who were limited English proficient and from different socioeconomic strata. Because one of the things that we noticed in our first wave of recruitment is that we were largely reaching people who, as I mentioned, were of Indian origin and of higher income and education. And so we've recognized that we really did need to diversify our cohort if we were going to achieve true inclusion of our community and gain useful information. And then in 2021, we received funding for our third exam to bring back our original cohort participants, as well as to recruit over an additional 1,000 participants of Bangladeshi and Pakistani origin, which is when we were lucky enough to add the New York City site, which will bring our eventual cohort size to over 2,000 individuals of South Asian background and a lot more diversity. And so, as I've alluded to, we recognized how important it was that the Masala study population reflect the heterogeneity of South Asian Americans, and that we really include people who may have less access to clinical research, to healthcare, and who may be experiencing a higher burden of cardiometabolic diseases. So this means people from diverse countries of origin, religion, individuals who were born outside the United States, who may be limited English proficient and had lower income and education levels. And when working with our South Asian communities, we recognized that there were barriers to research participation that were at the intersection of race, class, gender, and immigration status. South Asians are a racialized minority in the United States. They include a large population of individuals who may not be documented or whose legal status may be in limbo, as well as language barriers. They also experience being underinsured and uninsured, as well as lower incomes. And then lastly, we also discovered through qualitative work in our communities that there may be gender and cultural factors that affect willingness to participate in research and interact with institutions such as an academic medical center and researchers. In addition, there were barriers related to, as I've mentioned, access in terms of healthcare and transportation, awareness related to those language barriers, but also that physicians don't necessarily communicate about research opportunities with participants from diverse backgrounds. Racism and discrimination, as our prior speaker mentioned, where there are concerns about surveillance within South Asian communities, mismatched priorities, and less trust, as well as gender norms related to caregiving responsibilities, stigma, and health beliefs. And then, of course, the workforce, where we may not have culturally and linguistically competent workforce for being part of the research team. And so these are some of the challenges that we have experienced as we've tried to build this cohort. And so when we think about the engagement mechanisms that we use and with our community, we recognize that there are formal and informal engagement mechanisms, as well as different levels of engagement. And some of you may have seen this slide before, but there's sort of the lowest level of engagement where we are sort of just conducting outreach to the community. Communication is really flowing from the research team to the community, letting them know about this research opportunity. And as we increase the level of engagement to consulting with the community, involving them in the research design, collaborating with them, creating bi-directional communication channels, focusing really on partnership building and trust building. And then finally, to shared leadership, where community members are actually have final decision-making. And we have a really strong partnership that's focused on the priorities of the community and answering the research questions that they think are more important. And so the reason I just show this is because I want to be transparent that in Masala, we've sort of gone through different levels of engagement with the community members that are participating in this study. And I would say, right now we are somewhere in involve and collaborate in terms of how we are engaging with the South Asian community for this particular cohort study, although our research teams may have other studies where we have different levels of community involvement. And so one of the things, I'm going to speak mostly about our Chicago site, since that's where I am based and that's where my experience is, that we thought was really important is that we collaborate with a range of organizations that represent different sectors. For example, the healthcare system, the public health system, community-based organizations that serve immigrants, as well as federally qualified health centers. And that they are actually spread all around the Chicagoland area, Chicago being, right here, but that there's large South Asian populations that live in the Chicago metro area, and that we have clinical research sites that are accessible to the community because not everybody would want to come to downtown Chicago. And so we really tried to ensure that we collaborated with a range of organizations so that we would reach people in different parts of our state, have accessible clinical research sites, and that we use both hybrid, we use a hybrid study procedures where we complete part of the Masala study visit remotely over Zoom, as well as we have in-person components where people come into our clinical research units for various measurements and blood work. And another important aspect of engagement is how we were going to structure our study team, and that we were going to ensure that we had individuals who had both academic and community experience, that we demonstrated cultural and linguistic competence. Our team includes 2 community health specialists who are embedded at community sites. These individuals have trusted relationships and networks within our communities and are involved with the South Asian community in ways that go well beyond being part of a research project. Individuals are trained in research, recruitment, retention, and intervention delivery if it's an intervention study, but in the case of Masala, it's not. And we work with all our team members to learn how to communicate with each other and with our study participants, with a focus on respect, transparency, and equity. And because our study team has different areas of expertise, both academic and community expertise, we feel like one of the main focus areas that is important is that cross sort of communication within the study team and respecting the knowledge that each of us brings. We also have a community advisory board, and this is a picture from one of our meet and greets a couple of years ago. And our community advisory board has been asked to do several things, including giving us input on research materials and procedures, connecting our team to new recruitment venues and events, advising us on challenges we may face. They help us disseminate our recruitment flyers and social media messages. And they can help us interpret and disseminate research results and participate in manuscripts and presentations, as well as share knowledge about engagement and advocacy opportunities in our community. that, again, allow us to take the results we're learning from Masala and use them to advocate for greater healthcare access or resources for South Asian communities in the United States. Our Community Advisory Board also developed a brief PowerPoint presentation called Research 101, What You Should Know About Research. And the goal was to increase awareness and understanding about health research and why participation matters. It uses plain language and everyday life examples and analogies. It's available for our CAB members and our study team to deliver in community settings, and was presented by one of our co-chairs at the 2022 American Public Health Association meeting. And I think this is one example of engagement that actually seeks to build the capacity of our community to understand research and why participation is important, and not just focusing on them participating in like our one specific study. We also use these stakeholder academic resource panels, which are panels that bring 8 to 10 community stakeholders who have expertise related to a research project. And we ask them for feedback that can improve the relevance, feasibility of our research, such as sensitive study measurements and questionnaires, and strategies for overcoming recruitment barriers for specific populations, and then input on marketing and social media messages. And this is something that's done through our CTSA. We spend a lot of time with community presentations and tabling, where we work with community partners to find out what are people interested in learning about. And so we give health talks that are based on those needs and interests. We host discussion groups, and then we use those venues to distribute recruitment materials for the Masala study as well. And then one thing that's been really helpful for us is engaging the health system and clinicians. So we've created clinician-facing pamphlets to educate providers about why it's important for South Asians to be participating in clinical research studies, what the opportunities might be through our research team or through other research teams that are trying to engage the South Asian community, conduct brief presentations to clinicians, and then provide funding for electronic health record queries and health system outreach to patients. And this is one way to reach members of our community who do have healthcare access.
Nadia,
yeah.
if you could wrap up in the next minute, that would be great.
Yes, I'm almost done. So we also, of course, create all our study materials in the languages that are most commonly spoken by our participants, which include English, Hindi, Urdu, and Bangla. And our study team members help a lot with translation in plain language, which you may not always get through a translation agency. We also have ethnic media relationships, which is, I think, a really important thing that is often overlooked, to publish in local Pakistani Bangla newspapers so that people understand this opportunity and hear this message multiple times in different ways about what is this study, why are we doing it, and how can you participate. In terms of retention, we do a lot of town halls. We remind participants why it's important to stay in our study, and we have ongoing communication through newsletters for them and virtual town halls as well. Yeah, and then I'll just leave you with some of the perspectives of our research participants on being part of our Masala study. And I thought it was really interesting that people said they felt that they were finally visible, they felt safe, they were in good hands, and that it was a really great opportunity to develop friendships and learn more about their own health. Thank you.
Thank you so much, Nami, Josh, and Alex. I think what I was reflecting on during your presentation is that recruitment and retention of diverse communities in research has been such a vexing problem, and it's like a key priority area for NIH and other federal agencies. Yet your cohorts have been so successful in these efforts, and I think the audience really appreciates the innovations that you've brought to your work to drive this success. So I know we may have questions in the audience. While we're waiting for those, I'm going to open with one question. I think a common theme through each of your presentations and the implementation of your cohorts has been the need to expand cohorts iteratively to really reflect the diversity of Asian American and HPI subgroups. So what strategies has your team utilized to really scale and sustain and support the expansion of your cohorts, particularly in regards to diversity? How have you implemented those expansions over time? And I'll leave it to any of our speakers to jump in.
Well, I'll just get us started and say that I think it's important to recognize that there's a sea change happening nationally and with NIH. And so the support from NIH has been vital to every expansion and anticipated expansion for care. And that's just been fantastic to witness. And then I think for us, it's really been about, you know, having the right partnerships to be able to engage the communities that have unfortunately been left out of research for decades. The recognition of the value, the importance of the topic, the support from funding agencies, and then partnerships in the communities has been essential for us.
Thank you.
Yeah, for Amplify API, I think this is the directive. I mentioned the funders, right? We're not just going to certain cities. We're trying to go expansive across the whole country, and that community level, I think, is a theme that was mentioned. That's really important to us. We're trying to get to that grassroots level, but it's difficult when it's a broad country span. But it's, you know, the funders, our partnerships, being able to not only funding to establish getting more respondents and panelists to take the surveys, keep them engaged, but also to people for these companies, organizations to, and academics to use the panel.
And just I think one quick thing that I tried to emphasize was building the capacity of our communities to understand research and why it matters to participate, I think is very critical. And that work has to happen alongside, you know, getting the funding to actually do the research project.
Wonderful. Alex, there was one question for you that came up in the chat, so maybe we'll end with that chat, that question. So given Asian and Native Hawaiian Pacific Islanders are two different groups, can we expect more detailed NHPI data reports moving forward from Amplify API? And for the recruitment scheme, does this include Hawaii or any of the other US territories?
Again, that's our ultimate goal, to be able to look at Native Hawaiian and Pacific Islanders separately. One of the challenges that for the NHPI community, Vietnamese community, because it's a small part, it's harder to reach. So we are trying to, you know, get to that community level to how can we reach them? You know, and it even gets more specific, you know, Republican Vietnamese is something we're trying to get at as well. So that's key. And we're hoping to have data eventually on that level. Right now, it's all directional because it's a small sample size, but, you know, in the next year, end of the year, after that, we're hoping to be able to provide public information, but also for organizations to use our research to be able to look at the NH/PI community and hopefully separately down the road.
Wonderful. With that, we are unfortunately at time. Please join me in giving another warm round of virtual applause for our panelists. I think it was very inspiring to hear about the success of these cohorts and the really thoughtful and strategic ways that each of these investigators is thinking about sustainability of the cohorts and using these as resources for future research. So I will just let the audience know that following this session, we're hosting a 15-minute session consisting of brief pre-recorded flash presentations. We encourage you to tune into those. And we hope to see all of you at the remainder of this virtual conference. thank you again to Joshua, Alex, and Nami for your work and your presentations. Take care, everyone.